Good morning.
Good morning.
Yeah, we'll give it another second, I guess. We have, this is Christina out this week?
Yeah, she's on
Yeah, she's still on
vacation.
vacation.
I see. Okay. All righty. Excuse me. Good morning. We're going to continue on with our drug review. Make our way through all of them. Okay, so today we're still on the class 1 sodium channel blockers. We've discussed class 1A, which I remind is quinidine, procainamide, and disopyramide. We've discussed class B last week, which is 1B, which is lidocaine, phenytoin, and mexiletine. And today we're going to discuss flecainide and propafenone. And I have here morisocine, which is another class 1C, but I don't believe is any longer available. Okay, so propafenone and flecainide shorten the duration of the action potential by preventing late sodium sustained current. And so they prolong the phase 0 of the action potential more than any of the other subclasses of class 1 agents. And they prolong the QRS duration because phase 0 is prolonged and pushed out as sort of demonstrated in this cartoon. They dissociate slowly from binding sites in the myocytes, and so practically we would call that use dependency, and the QRS will be more prolonged with tachycardia. So that can sometimes be challenging because, of course, one of the side effects of any antiarrhythmic agent is the ability for it to be pro-arrhythmic and potentially cause arrhythmias. And so one of the concerns whenever you start somebody on propafenone or flecainide in particular is, are you getting ventricular ectopy? And so if you have sort of partial control of the arrhythmia, you can get QRS prolongation, particularly in tachycardia. So you can have like an atrial tachycardia with a more aberration than you're used to seeing in that patient as the medication effect becomes more significant, resulting in a widening of the QRS and could sometimes be mistaken for VT. And so it could be, in fact, if you misinterpret that, you could think that you're having proarrhythmia when in fact you're not. There's little effect on the action potential, and so little impact on the QT interval. So, but the QRS duration is very important and needs to be monitored. And generally, you really don't want to see more than a very minimal increase in QRS duration. If you see more than that, chances are you're approaching potentially toxic levels of the medication. So let's start with flecainide. The brand name of flecainide is Tambicor. It's rare that you hear that name anymore because at this point the med has been available as a generic for so long that people just call it flecainide, but you will see it listed as Tambicor. It's clinically useful mostly in SVT. Can be used for AVNRT, can be used for WPW, where it may in fact have some direct effects on pathway conduction, potentially reducing risk for rapidly conducted AFib. But again, unlike procainamide, where we think that effect is very reliable, it's not as reliable in that setting. And probably the most common place that we use flecainide is in the treatment of primary atrial tachycardias, particularly ectopic atrial tachycardia. It's especially effective for those. When it can be used for VT, typically has to be non-ischemic VT, and particularly is helpful for RV outflow tract VT or arrhythmogenic right ventricular dysplasia types of VT. It can be helpful. Now, the reason that flecainide is not used in any kind of ischemic disease is, and some of you have heard me say this before, but I'll just review it for our newer fellows. So in the early 1990s and late 80s, it wasn't really known what was the best antiarrhythmic agent to give to patients who had ischemia. So in the world of adult cardiology, as you know, when a person has a heart attack, has an ischemic event to their myocardium, the most common reason that people die suddenly is that they have VT or VF as a result of an injury to the myocardium. And if you're lucky enough to survive that and you have a lot of ectopy afterwards, it really was a little bit of the Wild West. Electrophysiologists and cardiologists didn't know what was the best agent to use in that setting. And so cardiologists would essentially randomly choose whatever they thought might be most effective. And uh, and so study was done called the CAST trial, in which they looked at this question, trying to figure out what would be the best agent, what's the safest agent. And one of the things that came out of it, and perhaps one of the most important things that came out of that trial or study, was that in the setting of coronary artery disease, if you were on flecainide, you were more likely to die than if you were not on flecainide. Now, that could be potentially a marker. People, perhaps the doctors were putting patients on flecainide who had worse coronary artery disease. But the bottom line is, in the present era, based on that trial, flecainide is never used in anybody in whom there is a consideration or a concern for coronary artery disease. And it got a very bad name because of that. And so the bottom line is it is an effective agent. We use it quite frequently in pediatrics because our patients almost never have coronary artery disease, but it is an important concern, particularly in the adult world. Again, it slows the upstroke of the cardiac action potential, reducing excitability, and its greatest effect is on the His-Purkinje system and ventricular myocardium. Interestingly, in the recent era, it's been demonstrated that it can inhibit the ryanodine receptor number 2 and affect calcium ion handling. And for that reason, in patients who have CPVT, who have failed beta blockade, or who have received multiple shocks from their ICD, despite that, being on beta blockers, flecainide can be very, very useful in that setting of CPVT, which is a relatively new observation and usage of the agent. In terms of metabolism, it has a very high bioavailability, and the peak serum concentration is anywhere between 1 and 6 hours after one has taken the tablet. Plasma half-life is 12 to 27 hours, so basically half to 1 day. And steady state, as in most agents, is achieved in about 3 to 5 days. It is eliminated by the kidneys mostly, so it has to be adjusted in the setting of kidney disease, and the rest of it is by the cytochrome P450. And it can decrease the metabolism of other P450 agents, sensitive agents, and raise their levels. So one needs to be aware of that when using this agent. So you really do need to have both kidney and liver function in order to be on this agent. Side effects. Proarrhythmia, particularly bad if you have low potassium levels. So you want to be very careful when prescribing this that the patient has a normal potassium. And again, the early signs are PR prolongation and particularly widening of the QRS. You really want to be very careful with that. And patients who are being started on this agent should have a 12 lead every day, carefully scanning for these changes, which could be a sign of toxic levels of flecainide. Flecainide can lower the ejection fraction and is a negative inotrope. Now, in patients who have normal ventricular function, the impact is very minimal. Sometimes people have asked, well, what if you have a tachycardia-induced cardiomyopathy that is sensitive to flecainide? It is true that the flecainide will be a negative inotrope in that setting. However, the positive impact of establishing sinus rhythm is so powerful that any negative inotropy associated with flecainide is far outweighed by the benefits of being in sinus rhythm in that setting. But one needs to be very careful when using that agent in the setting of someone with a tachycardia-induced cardiomyopathy, because you could take someone who's in heart failure and make them quite a bit sicker, at least temporarily. So you have to be careful with it. Again, it's a very effective and very helpful agent in that setting, but we do need to be mindful of the fact that it can cause a depression in ventricular function. And it can increase thresholds on pacemakers. So if you have somebody who has a pacemaker and has an arrhythmia and has a high pacing threshold, administration of flecainide could be an issue. Could also affect temporary pacing in the ICU. In terms of other adverse effects, it can have rare end organ effects. Again, we talked about the fact that it's negative inotropy. It can cause mild GI upset, but the most important and serious concern always, always, always is proarrhythmia. And so this is the reason why we would never start this agent in outside of the hospital setting because of its potential for proarrhythmia. It has a very narrow therapeutic index. It can be life-saving in patients who have very bad arrhythmias that are not responsive to other agents. But it is certainly in my career the agent that has most commonly resulted in serious problems for patients related to toxicity of an antiarrhythmic agent. And so it should always be administered in a hospital setting in the beginning. And one of the reasons that we don't like giving this agent to small infants is because it has to be compounded. There is not, unfortunately, a professionally, commercially available solution of flecainide. And so as a result, pharmacists have to crush tablets into solution. And so the classic problem or proarrhythmic story one gets with flecainide is the infant whose mother or father has been administering the medication every day. And when they get to the bottom of the bottle, there are more pill fragments, and the concentration of flecainide is greater at the bottom of the bottle than at the top, and can be very, very life-threatening. I've seen at least 2 patients come into the hospital in VT, barely survived because of the proarrhythmia associated with giving the wrong dose of flecainide inadvertently because of the difficulties of administering this as a compound. So we typically will ask patients and I will sit with the patient or ask the fellow who's on call or on service to sit with the patient and remind them that before every single dose of flecainide, they need to shake the bottle. That results in another issue, which is you then end up with a lot of bubbles in the bottle, but that is a better problem than giving too much flecainide. So from the moment the bottle is opened, a parent needs to very aggressively shake the bottle, and so that as close as is possible, each of the doses are equal, and that at the end of the bottle, one is not inadvertently giving too much. The levels of flecainide are typically increased if you're on amiodarone, quinidine, or even propranolol. And so the agent should be started at lower than therapeutic dosing for this. And I don't have this on the slide, but flecainide can be dosed either in milligrams per kilogram or milligrams per meter squared per day. I personally typically use it milligrams per meters per day. And typically it's in the range of about 80 to 160 milligrams per meter squared per day. Sometimes we'll start a lot lower, especially if we are already on another antiarrhythmic agent, such as amiodarone, which is a common agent that is combined with flecainide for the treatment of very challenging arrhythmias, often in infants. But it can be dosed in milligrams per kilogram, and I think it's anywhere between like 1 and 6 per kilo, something like that. Okay. Any questions about flecainide? All right. Propafenone, we're not going to go into too much. It's basically very similar to flecainide in its effects. It has a shorter half-life. It increases the refractory periods in a similar fashion to flecainide. It has a slight beta blocker effect as well. Commonly, patients can have neurological side effects like dizziness, nausea, or lightheadedness on flecainide. I'm sorry, on propafenone. And it is probably marginally safer than flecainide. I think reports of proarrhythmia are lower with the use of propafenone. Generally speaking, all of us are victims of our training, and so most people typically prescribe what they are commonly seeing when they were trained. And it's sort of funny, but I would say that for the large part, In the Northeast United States, most electrophysiologists and cardiologists feel much more comfortable using flecainide than propafenone. But in the Southeast United States, like in Atlanta and South Carolina, I think people are use a little more propafenone and less flecainide. I personally have never prescribed propafenone, but that is not because it's not a good agent. It's just I have a less comfort level, less familiarity with using it. But those who use it will tell you it's very effective. Stop with that on propafenone. Before we go on, any questions about any of that? Our class 1C
Do you know for propafenone, is it like similar in terms of it's usually compounded and things, just if we ever
has to be it has to be compounded.
Okay.
Yeah, so that would be a reason to use it, of course, if it did come as a commercial
Right.
compound, but it does not. So,
Right.
and I think you would have trouble finding it in this area, actually,
Yeah.
just because I don't think anybody prescribes it. Unfortunately, I was trained by the folks in Boston who don't use it pretty much ever. And I pretty much trained most of the electrophysiologists in this region or the people who trained the people in this region. So almost nobody is using propafenone now. But it does not mean that propafenone is not a good agent. I've often wondered about using it, but the problem, unfortunately, is that we don't typically use 1C agents on baby. We don't use 1C agents in older patients, right? Because if usually, and the reason is because if they have that bad of an arrhythmia in an older patient, we'll typically just ablate it because we have the opportunity and the ability to do that. And in younger patients, usually the patient is quite ill from the arrhythmia, and so we often are feeling uncomfortable using an agent for the first time on somebody who's sitting there in heart failure and low cardiac output and trying a new agent. Now, if all the other agents were failing, that would be a good reason to consider it. But usually what happens is you feel, there's always a very strong degree of urgency by everybody who is involved in the management of such a patient. And so basically, we haven't used it very much. But if any of you ever start using propafenone, I would love to learn how you use it and how often you're using it. So, and in what you're using it. But I think as a general rule, most people who use propafenone use it for very similar indications as we would flecainide, and the most common would be automatic tachycardias like EAT, particularly. Alrighty, so now we'll move on to we'll finish up with 2 or 3 cases. This is a teenager who had a mitral valve replacement, and this electrocardiogram was obtained on postoperative day 1. The question is, what is this rhythm, and what is the likely prognosis and outcome for this patient? I am going to toss this over to Dr. Khalaf.
Hi, good morning, Dr. Pass.
Good morning, Mohammed.
So I'm guessing it's some kind of a bradycardia. The QRS are widened or prolonged, maybe a junctional rhythm.
Well, do you see anything in front of the QRSs that would belie the diagnosis of junctional rhythm and suggest something different? These big spiky things.
Oh yeah. QRS. Maybe some kind of pacing.
Yeah, this is are we pacing the atrium or the ventricle here?
Maybe I'm just guessing. I guess it's the ventricles.
Yeah, well, you could do better than guess, right? I mean, the QRS is following immediately, right, after each pacing spike.
Yeah.
So if you were pacing the atrium, first of all, you wouldn't get such, you wouldn't capture the QRS. Second of all, if you were pacing the A and let's say it was conducting to the V, that PR interval would be way too short. It's not humanly possible to pace the atrium and go to the ventricle in less than 10 milliseconds. So, right, because we know the normal PR is like, 80 to 100 milliseconds in a child. So this is ventricular pacing. So let me see, Vlad, what do you think the rhythm is, though? So we know we're V-paced, but what's the underlying rhythm, do you imagine?
Um,
Is there a consistent relationship between the P waves and the QRS? There
no,
isn't, right?
it's like almost seems like some sort of heart block as the
Yeah, yeah.
it seems like it gets farther and farther, the P and the QRS each time.
Say that again. I missed the last sentence. I apologize.
It seems like the relationship between the P and the QRS are widening,
Right. Well, I think it would,
or actually the opposite even. Maybe
I
they're
mean, I think what
narrowing.
I would say is a more accurate way to describe that would be there doesn't seem to be a consistent relationship, right? We have a P wave here with a QRS, there's a P wave here and a QRS. And if you're trying to imagine that they are conducting, well, first of all, we know that the QRSs are paced, so they're not
Right.
conducting.
So then
Second
it
of
would be
all, as
complete.
you said, the PR is actually getting shorter, if you want to think of it that way. And there is no condition I'm aware of where that happens physiologically. So basically, the P waves are beating independently of the paced QRSs. So this is an example. This would be VA or AV dissociation, and this is complete heart block. There's no ventricular capture. This ventricular pacing rate is very, very slow. It's like 50. And so this P wave, for example, is coming in at a very slow rate after the last QRS. So if the AV node was working, one would imagine that you would conduct, right? If a P wave was sitting on the T wave, you'd say, well, maybe the ventricle is still refractory. But a P wave way out here is so far out, this should be conducting, and it's not. So this is, and we don't see any disruption in the R to R interval of the paced complexes. So this patient has postoperative complete heart block. Vlad, do you think that is surprising after a mitral valve replacement or something that you could imagine would happen if you were predicting, like if you were, look, this patient I think had just for the record, had I think a transitional AV canal and had prior work on his mitral valve or her mitral valve.
Yeah, I think it's unsurprising if you have a AV canal when you're also sewing some sort of new valve into the intraventricular septum or where the AV node might have been.
Right. So mitral valve surgery is always a risk for development of heart block. They can inadvertently hit the left bundle and the bundle of His, causing high-grade AV block. So anytime anyone's going in for mitral surgery, you should always at least anticipate the possibility that they're going to be in complete heart block, or at least some kind of heart block following it. Sometimes patients will conduct, but they'll have a new left bundle. That actually happened to my stepfather, who had mitral valve surgery a couple of years ago, and although a great result technically, has a big left bundle that was not there preoperatively. Okay, so the mother of the patient is at the bedside, Vlad, and is asking you, I'm very upset that my daughter is being paced. Is this going to be permanent? Is my child going to need a permanent pacemaker? What would you tell them on postoperative day 1 in somebody who has postoperative heart block and you're about 24 hours out from surgery? What's
I
the
would say
percentage chance that we will not need to pace this patient?
I mean, my initial instinct is it's likely temporary, like a post-operative phenomenon, but
You're right.
know,
It is likely temporary, but how likely? What's the chance? What's the percentage chance that it's going to resolve?
the I don't know, maybe 90% chance of a result.
No, it's not that high. You're a very optimistic person. That's good. But no, if you take all comers who've had a congenital heart surgery and who have come out of the operating room in heart block, about 2/3 of them will not recover, will recover conduction, I'm sorry, will recover conduction, and about 1/3 will not. Now, and so if you're in postoperative day 1 and you're in complete heart block, there's still a very reasonable chance that it could recover. Now, I'm not really aware of literature, I don't know that it exists, on different lesions. And the other thing that's interesting is sometimes a surgeon will come out with a patient who's in complete heart block and will say to the ICU staff, this kid's not recovering their conduction. I was all over that AV note. And then, post-op day 2, they're conducting. So the surgeons are not, in my experience, particularly successful at predicting when their patients are going to recover or not recover their conduction. Because remember, of course, the conduction is not labeled, although you probably are aware that there are now efforts to map the conduction system intraoperatively to avoid the development of heart block. Notably, the group in Boston, led by one of my former students, Lizzie DeWitt, is actually going to the OR for all complex surgeries, and they're moving a grid around looking for the bundle of hysts to label it for the surgeon to avoid putting sutures in that area, and they have demonstrated substantially reduced incidences of heart block following surgery. But so the answer is about 2/3 chance. And Vlad, when would we give up? Like, after what point is the chance of it coming back, like, let's say, less than 1 or 2%, do you think? So we're post-op day 1. I think we all would agree we would give it a shot. It's a little early to put permanent pacemaker in, but when would we say, I'm sorry, ma'am, it's not going to come back?
I feel like 72 hours. Too
How
soon?
long? How long?
72 hours? I don't know.
72 hours. Okay. See, you were very optimistic. Now you've become very pessimistic. Now, actually, typically the literature suggests that by 8 days post-op, something in the range of 96 to 97% of patients who will recover will have recovered. So usually, the rule of thumb, like if you ask an intensivist, they'll say 10 days, but really it's 8 or 9 days. And that originally came from a paper in Boston from about 30 years ago, based on like 100 patients. And then the study was repeated about 4 or 5 years ago using the FIS database with thousands and thousands of patients, and the number was shockingly almost identical. It's kind of funny that, a paper with 100 patients and a study with like 7,000 patients with heart block both came to the exact same number. It's about 8 days, you're at about 96, 97% recovery. So that's where the idea came that we wait about 7 to 10 days before we would consider putting in a permanent pacemaker. Now, sometimes we're forced to deviate from that. For example, if you have a very, very sick patient, let's say whose chest is open, and the surgeon is absolutely certain that they got the conduction system, and they're going to close the chest, let's say on post-op day 3. And this happened maybe a year ago. They asked me, should I put in permanent wires since the chest is already open? And we decided to do it. I think it was like post-op day 5 in that patient. And thankfully for us, we made the right guess, but we could have been wrong and have put hardware in for no reason. But the point is, we would typically wait 7 to 10 days and then consider permanent pacing in such a patient. And in a patient who had mitral valve surgery, we would almost always want to do an A and a V, have dual chamber pacing, because we would want to have AV synchrony, because AV synchrony will reduce mitral valve or tricuspid valve regurgitation. Of course, if it's a valve replacement, I haven't listed what kind, but usually it would be mechanical. But for AV valve replacement, almost always we would recommend dual chamber pacing. For other types, one could consider VVI pacing, but although in a teenager, we generally put dual chamber device in. So yes, so we would wait 7 to 10 days, and you would tell the family on post-op day 1, no need to worry just yet. that we're pacing, there's still a reasonable chance it could recover. So that's how we would think about that case. Any questions about any of that? Well, I think we are at the 7:30 hour, so I'm going to stop here. I hope all have a great day and a week, and I'll see you at sign out in just a half hour.
Thank you.
Have a good day, everybody.